Brilliant.
Can you see that?
I can. God bless you.
Okay, this is a term baby who was born at 39 plus 1 weeks with a biletic dissection weighing 3.28 kilos. During the antenatal scans, there was felt to be ventricular megaly with the ventricle measuring about 12.5 millimeters. So we just decided to scan the baby once the baby was born. This is the first scan. You can see the orbital ridge and the frontal lobes and the interhemispheric fissure there. The second scan that we had done, again, you see the interhemispheric fissure, the frontal lobes, the cavum septum pellucidum, the frontal horns and the corpus callosum. But we were looking at this wee bit here. It looks as if there's maybe like a wee cystic area, which we actually can see in the sagittal views.
Yeah.
I was looking at going through all the lectures again, and the one that Dr. Eamon had done, he had spoke about conatal cysts, and on the sagittal view, which we'll obviously get to, I think it kind of looks like that.
Yep, perfect.
Okay. This is the next one. Again, you can see the wee cyst area there, the third ventricle, cavum septum pellucidum,
Brilliant.
the corpus callosum.
Brilliant.
Okay. Again, with the next, you can now see the sylvian fissures coming in. We can still see this wee cystic area here.
Yep.
The choroid plexus here. And I didn't take a view of after I had saved the things, I realised I hadn't taken a full view of the orbital.
No problems. No problems.
Okay. So this is the sagittal view. You can see the cavum septum pellucidum,
yep.
the corpus callosum, the pons, and the fourth ventricle here.
Brilliant.
Okay, and this is the next view where you can see the cordiothalamic groove, the frontal lobe, parietal lobe, the thalamus here, the choroid plexus, and the temporal lobe here.
Brilliant.
Okay, and then here you can just see the sylvian fissure.
Yep.
So this is the same again of the left side where we had seen the what I thought was a cyst. And obviously it's just the kind of same anatomy here, but you can actually see the cystic area better here. And I thought I think in Dr. Eamon's talk, it said it kind of looked like a row of pearls, and sometimes there can be 1, 2, or 3.
Yeah.
I think there's kind of like maybe 2. I think that like there's 1 there and 1 there.
Correct.
So that's just that one, and then we had just did the RI.
Brilliant. That's perfect for the RI. Perfect alignment. It's the right place. So, yep, brilliant.
And that's that.
Amazing. Do you have another one?
Yes, I do have another one.
Go for it. Beautiful scan.
Which is this one. Can you see that one?
Yes, yep.
Yeah. This one, so this one that I wanted to share, it was actually because it was a term baby who had been diagnosed with achondroplasia, and I just thought that this was a term scan. He was 3.7 kilos. He was 38 plus 3 weeks when he was born, but he actually was about 40 weeks when I did the scan, and I just think it looks quite different than a term scan of other babies. His head circumference around about 39 centimetres, so he has got quite a big OFC. It was just to show that the
extraxial space.
The extraxial space is quite big.
Yep.
On these two, and obviously you can tell it's a term baby because of the gyri and sulci.
Perfect.
I found it quite hard to differentiate here. Like, obviously, this is the ventricles, but I don't know whether, you know, where the cavum septum pellucidum is. I don't know whether it's maybe just a way of taking it. He was quite a wriggly baby.
So on the left side, I definitely can't see it. Right side,
Yeah.
just yeah, maybe. Uh, Being a term baby, you may not always see it, but what I'd say is your ventricles are definitely quite prominent. You'd
Yeah.
normally expect them to be quite slit-like, and we know that babies with achondroplasia can have increased extraaxial space with dilated ventricles. So it's a brilliant scan.
Yeah. And that's just another one.
Yeah.
Is that the third ventricle here?
Yes.
Yeah.
Yeah. With the foramen of Monroe, you're demonstrating it beautifully.
Okay. Then we just did the VCR, which was 34.8%, which I think from reading the literature between 33 and 36 is
No.
normal.
Yeah.
Yeah. And this is just like the choroid, the plexus. And you can see how prominent the
Yeah.
axal space is. And that's it.
Brilliant.
The last one. So this is
Yeah.
his
Definitely increased extraaxial space. You can see the sulci and gyri so well. Well done.
here.
Yeah.
Yeah. I think it looks very different than other term babies that I've
Yeah.
taken.
It's a really nice one to kind of save. And again, whilst the ventricles aren't dilated by definition, they're definitely prominent.
Yeah.
And some of these babies can go on and develop hydrocephalus as well. So monitoring the head circumference is quite important.
Yeah. And then we did his RI index as well.
Yep. Brilliant. Very nice scans.
But
Yeah. And
so
you
I tried to do um, this view as well. I think that's the fourth ventricle there, isn't it?
correct.
And the cerebellum there
Yep.
and there.
It's a very nice ciliated appearance of the cerebellum. You can see the cisterna magna in the background. Very
Here,
nice. Very
I think
nice.
I tried to take another picture too. I think is it the sternum here,
Yep.
there, and that's it.
Brilliant. Beautiful scans.
Thank
Well
you.
done, Shona. Nashwa?
Hi, can I present?
Yeah, please, Nashwa, go for it. It's a very nice scans that we've just seen. We've seen a conatal cyst and we've seen prominent ventricles in achondroplasia.
Okay, so this is 38 weeks delivered by cesarean due to hypertensive mother. I did the scan by linear probe, linear E12, linear blue.
Yep,
Yeah. Just baby with no risk factor, only the mother is hypertensive, and I just want to learn how to do by this big blue with the full-term baby.
yep,
But after that, you can see in the left side, left
mm,
ventricle. Also, but I was confused what it is. Um, again here, the left side again, it is seen.
yep, yep,
Bulletin. So I really know this is like right,
yeah. This is
but
definitely
why it is
choroid.
extended a little bit in the ventricle, I don't know.
Yeah, sometimes in situations like this, you can get choroid, just an isolated kind of pocket in the middle. Uh,
Hmm.
and I mean, the key question that you'd ask is, I mean, the only other thing that this could be is a small grade 1 bleed that's resolving in the chorothalamic notch. For me, I think it's more like a choroid, just a remnant of the
Hmm.
choroid. And it'll be very interesting that if you were able to follow this up and it develop cystic change, then really it could be a bleed. But if it just remains like this for the rest of the time, isodense, without any changes, without any problems, it's just an isolated detachment of the choroid. Nothing that I would worry about.
Hmm. It is here looks like choroid, but we can see again, I don't know, here it looks like a cyst, choroidal cyst here, or
So that's
the
just
left
that's a
side.
very interesting view because it looks like you've got a septate ventricle, similar to uh, you know, and
Hmm.
I just think what you've got is a cut of that piece of clot in between. It's not septate ventricle. My feeling is it's just choroid. I would,
That's choroid.
yeah, I would struggle to call it a conatal cyst at this stage because it's only visible in one view. But
Mm,
I would strongly
mm.
recommend that. Are you going to follow this baby up?
هو I just did a scan for myself, but the baby for
Sure,
is term baby
sure.
antenatal scan show nothing. Um, so I don't know what should we do.
Maybe a little bit of cystic change medially. If I say, it would be interesting. Yeah, just when you look at it there, whether this is the whole of the hemorrhage and you've got a little bit of cystic change there, so it could be a grade one. Could be. At the moment, I'd keep both the possibilities.
Hmm.
But
I
again,
appreciate this and
very nice
I follow up.
linear views. You can see the ventricles really nicely. But with them, you can see the meninges, you can see the interhemispheric fissure, the calcarine sulci, which usually seen in a kind of mature baby. So very nice scan.
Yeah, هو linear I found linear is okay, but the problem if the baby is term or small fontanelle, it's little bit difficult to see everything
Yeah. Yeah. You'll have
clear.
to take
This is
multiple views. And hence, I mean, what I'd say is that really the backup should be using your curvilinear probe. And then if you want to look at the meninges or you want a clearer image of the more superficial regions with a higher frequency, you can use the linear. In particular, if you're looking at the extradural space, you want to look at the subarachnoid space, you really want to differentiate them. You're worried about hemorrhage or you're worried about possible remnants, CSF remnants, then yep, you can use the linear in that situation. But another really good example of use of the linear probe, Nashwa, very good. I think you
well,
having
the issue
both.
is the only probe available for me now because I moved to another hospital, so this is the only option for me in order to
No
do
problems.
bilinear probe.
Do you have an abdominal probe?
Yes, there is.
You can use the abdominal probe as well. And what you might have to do is try and set the frequency of the abdominal probe to about 8. So you can use that, and that'll give you a bigger footprint. So don't hesitate to play
Hmm.
with all the probes. The other thing I would recommend, I mean, if you've got techs coming in, they can set up a cranial ultrasound preset, which basically means that it defaults to a depth of about 6 to 7 with a frequency of about 8. And really, then I would say you'd get a bigger footprint, which gives you a much wider margin. So instead of having just this margin, you'd get something that's much wider like this. So
Hmm.
have a play
Okay,
with it. Yeah. Well
I
done.
will try. Okay. Yeah,
God
thank
bless
you.
you.
Thank you.
Fantastic. Uh, have we got Kunal?
Yes, I'm there. I'm there. Hi, good evening.
Yep.
So today I'll be presenting two cases. I'm sorry, over the last few months, I didn't realize that so many months have passed. I just realized last week that we are already done 3 months into it.
Actually,
And
actually longer. March, April,
uh,
May, June.
yeah.
So four. But don't
Mhm.
worry. What I'd say is that look, for those of you where we've peer-reviewed scans, I normally go through the videos, but at the end of it, what I'd like to do before I give your certificates out is just get a feel of how many scans you've actually done, and I'll take your word for it. And basically, that's what we'll be entering on your certification. So, don't feel too worried about the fact that we haven't reviewed scans. The other thing is
Mm.
obviously if you have any scans that you'd like peer reviewed anonymously as usual, you can always come back to me on WhatsApp and we can organize a one-on-one to have a look at any scans that you think are excessively difficult or very interesting and you're confused. Very happy to support you with that. That's not a problem at all.
Thank you so much, Dr. Alo. I'll be I'll be needing that help
No
for
problems at all. No
quite
problems.
some time. I think for next 3 4 months I'll be needing that
Yeah,
kind of help
absolutely fine. We don't
because
have any education set up in the last 6 months of this year because we're preparing the cardiac module. So again, what I'd say is just give me the heads up beginning of the week, and the Thursday and the Sunday are usually good days for me.
thank you.
No
So
problems.
I'll start with the presentation.
Sure,
My PowerPoint on my desktop was not working, so I'll just tell the history verbally,
sure.
and then I will start the images. So this is a 2 days old baby term. This baby is 39 weeks, was antenatally was delivered to a gravida 3 para 2 mother who was diabetic on metformin during antenatal period along with chronic hypertension on labetalol. She presented with labor at term and developed fetal tachycardia and non-progress. That is why she was taken up for emergency cesarean section. And she had high grade fever during intrapartum period, around 38 degrees. So when baby was born, baby was grunting and severely acidotic.
Oh dear.
At 2.5 hours of life, baby was ventilated, and present baby is on mechanical ventilator. X-ray was showing not consistent with the hyaline membrane, but it was showing multiple infiltrates bilaterally.
Hmm.
And there was high FiO2 requirement with CO2 clearance was very poor, and initial echo done was showing some findings of pulmonary hypertension as well. So the
Sure,
indication to do the cranial scan was a sick child with severe acidosis to look for any evidence of maybe meningitis or intraventricular hemorrhage because of that.
sure.
So, so I hope my screen is visible.
It is.
So I don't know how good are my images. This sorry, just sorry to say it's a pediatric head. It's not
No, no, no.
abdomen. I forgot
Absolutely
to edit
fine.
that.
It's
I
absolutely
forgot
fine.
to edit that.
Your images are
So
fine.
this is the C1 where we can see the interhemispheric fissure along with the orbital ridges are visible, and there is little bit of frontal blush which can be seen on the right side, but left side I think there is some dropout there which I was not able to fix it by trying to optimize the settings and all. I was not able to fix it.
No problems.
Then uh, this is at the level of C2 where
Hmm.
we can see that there is interhemispheric fissure with carpus callosum and cavum septum pellucidum and the anterior horns of the lateral ventricles.
Yep. It's a good image, good depth.
This is the C at C3 level where I was. I think I'm in between C2 and C3 somewhere, where the third
Correct.
ventricle, the it's still not visible.
Correct.
Then mm,
You're just
this
getting the third ventricle appearing in this image.
this
Yeah,
this
correct.
this is okay. And now the lateral ventricles are slit-like for a term baby,
Hmm.
as it should have been.
Correct.
Now we can see that the cerebellum and the brainstem is little bit visible to
Sure.
posteriorly.
Yep. Just to be aware, you're just losing the back of the image. And it might be
Oh,
because you're using the abdominal probe. So you might
hmm,
just, if you want to zoom out a little bit or reduce your depth.
okay.
but good image. Yeah. My
Mm,
only comment about the images at the moment is I'm just a little bit worried that the gray white matter differentiation, frontal blush was
mm,
visible in the frontal lobe, but
mm,
again, it's a pretty dark image. Gray white matter differentiation is not as good. I mean,
mm.
neurologically, were you happy?
The child is sedated and ventilated right now.
Sure.
So
So it's a little
I
bit
am,
tricky.
I don't know if it is because I could not see a lot of this gyri and sulci. So
Exactly.
I don't know if there is a cerebral edema or something. I
That is the
have
thing
no.
that I am slightly concerned. Even your ventricles, I mean, at the moment, they're very small, very slit-like,
Mm,
and the gray white matter differentiation that you should normally see, uh, I just worry about that. So it's just very interesting. Is your
mm.
CRP elevated?
Yes, yes.
Yeah.
It's
Okay.
it has
Yeah.
got the CRP is around 80, procal is 160, and
Wow.
there is deranged coagulation as well.
Yeah. Yeah.
Mhm.
Okay. Carry on. Yeah.
Okay. And this here we can see the bilateral choroid plexus
Mhm.
in the body of the lateral ventricle.
Mhm. Yep.
Then, yeah, the choroid plexus both looks similar densities, so they look
Yep.
okay.
Yep.
This is gone the posterior most, the
Yep.
the the parietal blush. Yeah, the most for C6, C's at C6
Yeah.
level.
You're getting a little bit of ventricle there as well. So you just need to go a little bit more posteriorly.
Okay.
Yeah. But it's good enough to be able to interpret. Well done.
Now starting the sagittal. This is the mid sagittal. Here,
Brilliant.
here we can see that the that guitar kind of
Yeah.
structure for
Yeah.
the this is the your corpus callosum.
Yep.
This is that little bit of ventricle. Then your the
Choroid at the back. Yeah.
choroid at the back and extending down towards the cerebellum,
Yep.
and in front the fourth ventricle,
Yep. Correct.
and on the this is on the right side, the S2
Yep.
mid sagittal, showing the caudothalamic groove and the choroid, and
Correct.
this part is your caudate nucleus and the thalamus.
Yep.
And
Brilliant.
this is the that parietal lobe blush and
Yeah.
the temporal lobe.
Yeah. This looks more reassuring actually. To see the blush in this view, that looks more reassuring. So that's good.
Then going back towards the mid sagittal, going
Yep.
towards the left side. On the left side, multiple attempts. I tried almost for 5, 7 minutes. I was not able to get a good view for showing exactly the choroid and the caudothalamic groove. The best I could get was this one.
Which again just raises the possibility that you may have an element of cerebral edema. Here you've definitely got the caudothalamic notch with a little bit of choroid lip. So
Yes.
yeah, well done. I mean, you know, my compliments for persevering. It can be quite tricky. We do see some sulci at the top. So yeah, is his sodium low? Can I just ask?
Sodium, yes, it is. It is. It
Okay,
is. Hmm.
sure.
On sodium, both hypocalcemic and hyponatremic,
Yep,
both. Mhm. This where we can see little posteriorly the choroid, we can see
yep,
little bit.
yep. Well done.
Then these are the most extreme sagittal on the left side.
Sure.
Then I tried the mastoid view. I tried both coronal and axial,
Yep,
but I cannot make any sense out of it. Which this is the right side because
yep,
baby's head was fixed on the right side. So I tried on the right side. I don't know if you can make any sense out
I
of it.
can.
I was not able
S-
to figure out which is the like which side should we see the cisterna and which side should we see the cerebellum. I was not able
So
to figure out that.
I'll just annotate it for you. So it's a decent image of the right cerebellar hemisphere that you can see over here. That's the fourth ventricle that you see. Cisterna magna will come on this side. And it's not
Okay.
unusual in term babies. You've got a very small window. So because your window is so small in terms of the joint, the where the sutures fuse, it becomes quite
Okay.
challenging to be able to get mastoid view. So you've definitely got the right. And one of the things that you can do if you're really keen to try and look at the cerebellum is do the right and left views separately. It just means
Okay.
that you're closer to the left lobe of the cerebellum. So if you're unable to get them in one view, you can go and do the mastoid views separately. But I can see the right cerebellar hemisphere with the fourth ventricle here. So you
Okay.
can see its ciliated appearance that you get at the
Yes.
peripheries.
Yes.
So well done. It's a good attempt.
Yes. This was I tried another view for the mastoid only.
Yep. A little bit more difficult to delineate things over here.
Yes.
Yeah.
Hmm.
But the previous view definitely. And like I said, try to do the mastoids separately if you're finding that you're not able to get the opposite hemisphere.
Okay. Sure. I will do
Brilliant.
that.
A follow-up scan in about a
Yes,
week would be
I
very
yeah,
nice. Yeah.
I
Yeah.
will follow it up. I will
Yeah.
do that. And second one is a preterm baby delivered at 27 weeks, at present 5 days old, day 5 of life, delivered to gravida 2 para 0 mother,
J.
and she came with 1 week of leaking. She was an unbooked case at our hospital. So she presented last week in the beginning of the month with leaking.
Hmm.
And that time she was given some steroids. And within a week, she went into labor and
Sure.
she delivered by normal vaginal delivery. And antenatally, there was nothing significant as such, just apart from preterm labor
Yep.
and premature rupture of membrane. This baby also similarly septic at birth, but thankfully was we were able to manage on non-invasive with biphasic CPAP.
Amazing.
We did not have to intubate and give surfactant. So the the images in this was little difficult. I feel probably because of that continuous pressure of the headband,
Yep.
the
Yep.
frontal bones were completely pushed behind. So the anterior fontanelle had become even tinier, and the window was
Smaller.
baby was smaller, and baby was moving also a lot.
Sure. Sure. My help there is what I'd say is that if the baby's stable, and that might not be the case, is what you can do is get the nurse to take the hat off, to keep the prongs in the mouth, and keep the mouth closed while you're doing the scan to be able to keep the peep. And that
Okay.
means that
Yeah,
the head.
I did that. I did
Sure.
that.
Sure.
I
Well
took
done.
the help of the nurse. We removed the headband.
Well done.
We fixed the that mask of the CPAP with the help nurse was holding, and then I was trying to do it.
Sure. Sure.
This is the yeah. So this was the best I could get
No
with
problems. No
the
problems. You've got
C1.
C2. Yeah. C1 and C2.
Yes,
Yeah. Yeah.
yes, somewhere. Then here in this we can see little bit of the ventricles
Yep.
and the septum pellucidum with the
Correct.
interhemispheric fissure.
Yep. Yeah. Perfect. I think the important message that I want to give people is sometimes you might not be able to get scans because of the nature of the baby. The question is not always getting high quality scans. The question is, does a screening ultrasound show you pathology that is significant? And for me, when I look at these scans, in terms of being able to interpret significant IVH and parenchymal kind of hyperintensity, we'd be able to do that. So please don't feel worried. Well done.
Mhm. So this is at the level somewhere, but I think we can see the Somewhere here, the third ventricle.
It's a little bit tricky, but I can
Yeah.
definitely see a midline cystic structure, which I think is the cavum. And
This,
then
yeah.
the right ventricle with some choroid is definitely visible. Yeah,
Yes, yes,
yeah.
yes.
But good depth. You've got the whole brain. And from the parenchyma, I can't see any areas of hyperintensity so far. Yeah, now ventricles are
This,
visible with choroids. Yeah, well done.
this, here we
Yeah,
can see bilateral choroids here.
well done. So just if you go back, yeah. So
Yes,
just to kind of reassure people, these aren't cysts. Uh,
these two on the,
yeah,
yeah.
they're not
Right.
cysts. They're
Mm.
basically, it's a little bit of artifact that you're getting over there. So commonly seen, especially like because your gain settings are a little bit on the low side.
Oh,
So it's not unusual that the paraventricular brightness there might be interpreted that way. So they're not
oh.
cysts. This is normal.
And this is C6 going
Mhm.
posterior most.
A little bit more bright on that left than on that right side. When I look at this image,
Yeah.
so it'll be very interesting
Yes.
to see the trigonal view when we look
Okay.
at the left side in
The
your sagittal
side
sections.
steps.
Yeah,
This is the mid sagittal.
very nice.
So here we can see clearly the cavum, then we can see this the structure of the ventricle, third, fourth
Yeah,
ventricle, and the cerebellum,
and the
and
cavum
probably
vergi, very
yes,
nice cavum
cavum
vergi.
valve.
Yeah, very
Yes.
nice. Cerebellum is seen, fourth
Mm,
ventricle, very nice.
mm. This is another same at the mid level only.
Yep, brilliant.
Then this is going towards the right.
Mm,
So here we can see this caudothalamic groove and the choroid
yep,
most likely.
yep. So your gain settings are quite high here. What I do
Okay,
is I would try to go in with depth by a centimeter just to
okay,
fill the image a little bit more in your screen and
mm,
just try to drop your gain settings a little bit in this setup.
okay.
Yeah,
This
brilliant.
is the
Yeah,
outermost.
yep,
This I was trying the right, on the
left side.
one sec left side, but mm, clearly not managed to.
No worries.
This
No,
this probably is the I think the caudothalamic groove and the
correct.
choroid plexus.
It's a very good attempt. It's a very good attempt. And, sometimes it's the probe along with the baby moving that creates the problems. But it's a very good attempt. I mean, for me, at least, what it shows is there's no major significant IVH. And parenchymally, I mean, that left side, just the flare that we have to keep an eye out
Yes,
on. Yeah. Will you be scanning this baby again?
yes, yes. I will be.
Okay.
This baby
So,
will.
yeah, great.
Mm,
It'll be really nice.
mm.
When we do the one-on-one next time, if
Yes,
you have a
yes.
follow-up on this for us to be able to
Okay,
compare.
okay. I will
Sure.
do that. I will do that. Within a
Brilliant.
week's time, I'll repeat it once again.
Yeah. No problems at all.
And this is the outermost, where the parietal and the temporal.
Sure.
Then
Brilliant.
this one was the mastoid I tried for this baby.
Yep, this is the reverse mastoid that you're getting. A little bit tricky to interpret at this particular point. I can definitely see
Mm,
the brain stem
mm.
in the middle.
This part is the cerebellum,
Yeah, it is.
this ciliated.
Just
Okay,
remember your probe orientation is the opposite way around.
okay,
So just
okay,
very important to keep your probe orientation so that the marker always points towards the eyes if you're keeping
uh,
it coronally, and
okay.
always upwards if you're keeping it for
Axially.
the axial view. So
Yes.
just, yeah, you reverse the probe around. So what you're seeing basically here is probably an element of the brainstem. This is the cerebellum that you see, and this is
Mm,
the area of the cisterna magna.
okay.
It's a really good attempt.
Oh,
Well done, sir.
Thank you so much.
No
Thank you
problems.
so
God
much.
bless you. This is just
Fine.
another, yeah,
Yes, another mastoid view which I
yeah.
was trying. I was trying both axial and coronal. So yeah.
So possibly next week, when we
Yes,
do a
hopefully.
one-on-one, let's
Yes,
try
I
and see
will.
if we
I
can
will.
get a better image. Yeah. Well done.
Thank you.
God bless
Thank
you,
you
sir.
so much. Yeah.
Amani?
I'm
Yes.
very junior to you, Dr. Alok. Don't call me sir. I
No, no,
am
no.
I
There's
am I
there
am
is no
really, really, really,
hierarchy.
really
There's no hierarchy in our meetings. See, at the end of the day, we give each other respect. They're just different ways of doing it. So please, don't worry about it.
Okay. Good afternoon or good evening. Yes.
Good evening, Dr.
Um,
Mani. How are you?
good evening.
God bless you.
All right. Thank you. Right. So I have this case which got two scans because one is a follow-up. So this is a mother who's 36 years old, gravity 3/2, two previous sections. This pregnancy is being okay apart from urine infection. She came in with low-lying placenta, oligohydramnios, and received a full course of antenatal steroids. This was at 25 plus 1 weeks gestation. Baby was 700 grams and born in good condition. We did not need to intubate the baby. Was on non-invasive and received Lisa.
Brilliant.
Then day 6, the baby developed abdominal distension. Since we couldn't increase the respiratory support, worried about the abdomen, we electively intubated the baby and we started second line antibiotics. So the first scan, he had one on day 3, which was normal, but this is the one I did on day 6. It was done with the radiology department machine. That's why it's good. So this is the orbit.
Yeah, perfect.
And then the ventricles and septum cavum pellucidum.
Correct.
Um, and then again the ventricles, Sylvian Fisher. The only thing I felt here was the cavum septum pellucidum was a little bit larger than I would expect, but apparently it was passed for normal.
Yeah, it is. So it can
Yeah.
be larger than the ventricles as well.
Yeah.
Just to be aware that obviously if your baby has cerebral edema, then the ventricles might be a little bit smaller. But in this case, you've got nice white
Mm.
kind of Sylvian fissures. Ventricles look good. Just a little bit bright inferior to the ventricles. Be just interesting to try and see what we see when we see the sagittal views. But it's a brilliant image. Can I just say, your depth, capture of the image, capture of the anatomy. It's brilliant.
Thank you. And then again, the ventricles, septum cavum pellucidum, Sylvian Fisher. Would you say this is here the third ventricle
Uh, n-
beginning or?
it's probably the beginning, not very visible in this view. I think once you go a little bit further back, you'll be able to get it. Yeah,
Okay. And would you say here is a cerebellum or still
starting
I
to
need to
appear.
put?
No,
Yeah.
starting to appear. You're correct.
Okay. So here's choroid plexus beginning and cerebellum.
Yep.
Would you see the third ventricle anywhere
No,
here?
it would be in the view before. So you've gone to the
Okay. So,
trigonal view. So kind of
yeah.
C4 is the view where you'd see it normally. I wouldn't be too worried about it because if we see the ventricular system in the sagittal views, that would be sufficient as well.
Sure. Okay. And that's the right at the end, posteriorly at the occiput. Sagittal view midline.
It's brilliant.
So corpus callosum. Here is the cerebellum, the
Yep,
pons, fourth ventricle here.
correct. And you can see the third ventricle as well.
Yeah. Is this the third ventricle?
So I'll just highlight it for you. So this is
Please, yeah.
basically the third ventricle. That's the fourth ventricle,
Okay.
cerebellum that you can see. And this is the whole of the ventricular system.
Okay.
It's demonstrated beautifully. And can I just say, you've demonstrated the corpus callosum anterior to posterior. It's brilliant. You've got a lot of extraaxial space. It's a very immature baby. And what you've really got here is you're demonstrating what is the parieto-occipital fissure,
Okay.
which is
Okay.
commonly seen when the baby is quite immature. As the brain enlarges, becomes more mature, this becomes
Mm.
less prominent, and then finally you kind of see an overlap. So it's a brilliant image. Well done.
Okay. And this is the right side. I tried to get the whole C, but this is the best I could do.
Well done.
Yeah. Okay, so I don't think there is any bleed. This is just the choroid plexus to me. Maybe a little bit of a flare, but not sure if it's significant.
It's triangular.
Yeah.
At this stage, I'd probably class it as just blush.
Okay.
Yeah.
And then that's the right still.
Yeah, the right definitely it's bordering on grade one. Uh,
Mm-hmm.
Definitely something that needs follow-up at this stage. Yep,
Okay.
definitely something that needs follow-up. Yep, both
Okay.
sides. Yep.
Yeah. So when I first saw this,
Mm,
I felt it was normal and just a choroid. But I think when I reviewed my scan, because I will show you the follow-up scan,
yep.
I felt maybe there is a bleed here. Is it brighter than this part?
It's irregular and it's quite
Mm,
bulky, so it
mm,
does raise the possibility that there
mm.
might be a bleed there.
Okay.
Yep,
And that's the far right
yep.
and left. Again, it's not a proper C, but just to get a idea. So when I reviewed the image, compare this one to the other one, I felt this one is more smooth than the right
Yeah,
one.
correct.
So whether that's the right one, that's where the bleed is it
Uh,
possibly?
Possibly. It would be interesting to follow it up. My only other comment is the region of the caudate is very bright, and you remember we had brightness on the.
Mm-hmm.
So it's just, again, the follow-up images would be very interesting to see.
Okay.
Yep,
Yeah, that's far left. Okay, so I felt was normal size ventricles. That one I did it initially, and the cavern septal pellucidum slightly dilated. I felt the parenchyma was okay. I couldn't see anything apart from that blush.
yep.
So, subsequently, the baby became very sick. We were not able to extubate that baby, and there were chest X-ray changes, needed nitric oxide, received multiple antibiotics. We did not have any positive culture apart from the ET secretions. So, and at some stage became unwell, needed inotropes. For some reason, for a month, we did not do a scan because the baby was unstable and people were concerned about the status of the baby.
Completely, completely.
This
Yeah.
is just to give an idea of the fluctuation of our blood pressure at that stage in this month. You see just going up and down. The oxygen most of the time was needing oxygen of 100%.
Mm,
This the saturation were again up and down.
mm, mm,
This is the X-ray, so you
mm.
can see what's white
Yep.
purple. And then we did a scan, and we were surprised by the size of the ventricles. So this is the orbit that as far as I could go,
Mm,
and I can see that dilated ventricles even up to here. Cavum septum pellucidum, we say interhemispheric fissure.
yep.
And is this the temporal
It's the temporal
horn?
horn dilated.
Yeah,
So both temporal horns actually
yeah.
dilated. You're right, very
Mhm.
dilated frontal horns.
Yes.
And I mean, this is slightly further back. So
Yeah, it's not as far as, yeah,
yeah, so you're getting a little bit of the third ventricle there, which is dilated. Very
yeah,
worried, very
very
worried.
worrying.
Yeah, very worrying
But
that
here,
you've
yeah,
got leukomalacia. Yeah, yeah,
and then, yeah, again. So that's, these are the ventricles.
yeah,
Okay. So this, do you say this is the third ventricle?
correct.
Okay, and these are the
Temporal
temporal.
horns. So just
Okay.
so that you can see, this is the foramen of Monroe. So communicating lateral ventricle with the
Mm,
third ventricle. Yeah,
mm, mm.
brilliant. Yeah,
This give image, yeah,
not great for the baby, but
again.
yeah.
Yeah, so that's again third ventricle,
Yeah.
and they just again dilated. Is that the part where you would expect the cerebellum to
Yeah,
be?
that
That.
would be where the cerebellum is. It's a little bit
Mm,
hypodense at this point.
mm,
The areas that really worry you, I mean, there's dilatation, is
yeah.
this area over here.
Sorry. Yes. Yeah.
Yeah, where there's leukomalacia. That is really worrying. Yeah.
Mm.
Hmm.
So again, that's another image. And that's, I tried to get to see if they can get the choroid plexus. Would you say this is
Correct.
beginning of choroid plexus? Okay. So
And you've
I
got clot.
can't see them because the ventricles are so dilated. Mhm.
Yep.
Again, try to measure the VI.
So my only comment is just with the
Mm.
VIs, uh,
Mm.
you'll probably have a larger VI.
Yeah.
Yeah. So just if I highlight that the VI here will be less as compared to the VI over here.
Okay.
So you really want to measure it to the lateral most margin as far as you possibly can, because the innermost margin over here will give you a slightly, this is correct, this one, absolutely no
Mm.
problems with it. You want to
Mm.
just make sure you're measuring it from the midline. So
Okay.
yeah, but well done.
Okay. Again, try to go as far back as I could.
Yeah,
So this, you would say this is the Malaysia here.
yeah, yeah. And
Mm.
for me, I mean, the question is what's happened, and there are two possibilities over here. You've got
Mm.
clot on that right side, so an element of post-hemorrhagic hydrocephalus. But
Mm.
how old is the baby now? 4 weeks?
Baby at this stage was, yeah, roughly about 5 weeks.
5 weeks. Okay.
Mm.
So, I mean, infection would be the other thing for the regions. Normally,
Mm.
you'd start seeing leukomalacia in the periventricular areas as opposed to the kind of frontal areas. Uh, and, the only question that I'd ask is very close to the meninges. So the possibility that there's infection as well can't be completely excluded.
Yeah.
But yeah,
I
very,
mean,
yeah,
yeah, blood cultures were negative. We did have a raised CRP, but because of baby was unstable, we're not able to do an LP.
completely understand. Completely
Yeah.
understand. I think, in
Okay.
those situations.
Yeah. So here I tried to get a midline, but so would you say this is the third ventricle
Correct. Dilated with some clot
or
inside. Yep.
yeah, fourth ventricle here?
Just about. Yeah. I think you've got the cerebellar view coming in here, and the fourth ventricle
Mm,
would be here. A little bit difficult to kind of say whether that might be an element of the temporal horn. Uh,
right.
but I think you're right. That is the midline because I can definitely see corpus callosum here.
Mhm. Mm,
And again, you can see this area of leukomalacia right at the top.
mm,
So, yeah, dilated ventricle uh, with, I suspect this is the midline because you can see the third ventricle with clot in between.
mm,
Well done. It's never easy. I always
mm,
struggle. I really struggle with
mm.
this when there's hydrocephalus. So, with my compliments.
Again, tr I was trying to get a clear mid-sagittal view, but again, so this this is this the clot in the third ventricle?
Correct.
And what do you think this is?
So, I just, my, I think this is a cerebellum.
Mm,
I think this is cisterna magna. And I think
right.
this is fourth ventricle. And the fourth ventricle is also dilated,
Mm,
which would suggest that you've got obstruction at the level of the foramen of Magendie and foramen of Luschka, which can happen when you have arachnoiditis post-infection, because
right.
the whole of the ventricular system here is dilated, third,
Yeah.
fourth, going all the way up,
Mm,
which usually indicates a CSF outflow problem
yeah.
at that level, which is usually the level. So foramen of Magendie and Luschka kind of uh, towards the cerebellar view go into these spaces over here. So
Mm,
it's so can I just say it's the first scan I've seen with a dilated fourth and third ventricle with this group. So
mm,
I'm really grateful for you presenting it. Thank you so
thank you.
much.
Thank you. Again, yeah.
Yep.
Yes. Okay. And then that's the right side.
Yep.
So now would we say this is a bit of choroid or this is a bleed or
This is a bit of choroid. I can't see clot over there.
right?
There is a very bright ventricular margin here, not so bright over here.
Mm,
So whether there's an element of ventriculitis, and then again, what you can see is that area of
mm,
leukomalacia coming in, which is more in keeping with the periventricular leukomalacia that we'd see.
mm.
Yep,
That's
yep,
as far right you go. So plot again here.
correct,
Yeah.
which we saw. Yeah,
And again the right side. So not sure what this is. I think I tried to go down to the midline, but
it's a midline view again, probably in between the midline and one of the lateral views. This is the left. Yeah,
yeah.
brilliant.
So it's the left again.
Yep,
Clot again.
yep,
Yes, yeah.
yep. Dilated ventricle. Yeah,
Mm, that's as far as I go. So yeah, that's it. So a baby has been transferred to neurosurgical unit. I
yep,
think they just wanted to monitor.
yep.
Yeah.
Brilliant, brilliant,
Thank you.
brilliant images, and lots to learn, even for me. It's a long time since I've seen a dilated fourth with a third ventricle. It's usually you get clot which obstructs the third ventricle, which means the fourth ventricle tends to be collapsed. So this kind of could be infective as well, besides just being post-hemorrhagic. So brilliant,
Okay.
brilliant.
Um,
Yeah,
is there time just to
yeah.
present a quick one? Yeah.
Please, please.
So
This
this
time,
is
this time, this time.
thank
We're
you.
only doing peer review today.
Okay, so this is one of my very early scans. So 26 weeks gestation, mother multigravider, healthy lady. Parents are not related. So she presented to A&E after a minor fall.
Mm,
Went into labor, baby born, non-vigorous, intubated at birth, received surfactant, initially minimum ventilatory settings. The only thing that we have noted that this baby had talipus,
mm,
but nothing, no dysmorphic, other dysmorphic features as much as you can detect in a 27-weeker. So we did a day 2 scan, and I did that with a linear probe. And that's one of my first scans, so excuse the quality. So what I thought at that time is that there is definitely flare or bleed here.
Uh,
There is
Dr. Amani,
midline shift.
you're
Yeah.
not in slide view. You might have to just go to slide view
Oh, sorry.
so that picture at the
Can you
bottom.
see?
We can see your images, but the slides aren't moving.
Oh, okay.
So you just have to go into slide view, which is that button at the bottom.
Here.
So if I just highlight it,
Yeah,
this one, if
I
you just click
can't.
on it. The alternative is you could just close your presentation and
Can you,
open
is
it again.
it moving now?
No,
Okay. Can I just close the presentation and come
close
back?
the presentation, come back. Yeah,
Mm,
brilliant.
sorry about that.
No, no, take your time.
Is that okay?
Now you'll need to share.
Okay. Sorry.
That's okay. Brilliant.
Okay. Can you see it now?
Perfect.
Okay. All right. So that's the background. Healthy lady, 27 weeks gestation, presented to A&E after minor fall. Baby born non-vigorous and then received surfactant. On examination, the only thing we noted was the baby had significant talipus, but nothing else in terms of dysmorphic features. So I did this with a linear probe,
Hmm.
and it was a day 2.
Hmm.
So what I felt is that obviously my gain is very high, but there is a bleed here
Yep.
with a midline shift
Yep.
spotting
Absolutely.
the
Yep.
ventricles.
Yep.
So this is the right ventricle and this is the left ventricle. This is cavum septum pellucidum.
Yep.
And again, this is not clear exactly what it is, but you can see brightness all
It's
over.
a brilliant image. It's a brilliant image. So can I just say, was there instrumentation in this baby?
No, no,
Okay,
it's a
and it was
cesarean.
okay.
Yeah.
So you've got the midline, which is shifted.
Mm,
You've definitely got this area over here. Now, why it's brilliant is because you've got brightness and you've got a hypoechoic region over here. So
mm,
that, from my perspective, is definitely causing an element of midline shift. Now, the question is what this is. And over
mm,
here, what you can see is a hyperechoic margin again with a hypoechoic lesion. Now, it could represent blood in the parenchyma, but it could also represent a subdural or an extradural bleed.
mhm.
So, yep, carry on. Let's see what the rest of your
Ag-
scan looks like. Yep,
Yeah, again, more or less
yep,
similar image, but right. So here is a parenchymal bleed, midline shift? Is
yep.
this a bleeding in the right ventricle?
So you're right. So there are two things that are visible. That's definitely hemorrhage, clot in that
Mm-hmm.
ventricle with a hypoechoic margin. And now for me, I think this is intraparenchymal as opposed to extradural because actually, you can start seeing breakdown, and that would, with an extradural bleed, you wouldn't start seeing parenchymal breakdown.
Mm.
So, how old is the baby?
Baby was day 2 when we
Okay,
did the scan.
okay.
Yeah.
Yep.
So
Yeah,
again,
definitely intraparenchymal
mm,
breakdown. Yep,
mhm,
no doubt.
mhm.
Brilliant image. Yeah,
Okay.
not good for the baby.
Yeah. So yes, that's again the posterior. I tried to get a midline sagittal, but it looked like everything was pushed. So
Yep.
it was difficult for me at that stage to determine what exactly is what.
So
Um,
that is the cerebellum. This is the
okay.
cisterna magna. This is
Mm-hmm.
basically the midline ventricle. This is probably corpus callosum. And you get
Right.
this large area breakdown. Again, you can see the hyperechoic margin over here.
Mm-hmm.
So, yeah, I mean, the question is this the whole bleed, which is causing compression of the ventricle, with that being one of the areas of breakdown? Uh, I mean, this would almost certainly, if you started seeing breakdown, be antenatal.
Yeah.
Yeah, this is not likely to have happened just within the last 24 hours. You're seeing
Mm.
breakdown and cystic change. This has happened. Now, a very big kind of concern would be the platelets, the risk of non-alloimmune thrombocytopenia. Are they okay?
Platelets were normal. There was deranged clotting.
Yep.
Uh, but otherwise it was fine. There was a drop of HB,
Hmm.
I think on day 3 or 4. But
Okay.
yeah. So again, right and left. So do you think I mean, this is bleeding here also?
Possibly,
Mm,
but definitely what looks like a mass lesion over here.
mm,
And the question is intraparenchymal hemorrhage, which doesn't quite fit with the territory. If we look at it, it's extending from the midline to the lateral ventricle with breakdown. CRP was okay.
CRP was fine, but
Yeah.
the baby became unwell later on, and we felt that it's probably sepsis, but we'll get to that.
Yeah. Yeah. No problems. Yeah. Yeah.
Okay, so that's the left side again.
Yep.
Yeah, and
Yeah. It's really bad on the left side. Yeah.
yeah,
Sorry. Yeah.
and that's the far left again.
Yeah. Yeah.
You see, there's septation here.
Yeah.
So we started to get worried, and as I said, mother reported that she was absolutely fine, only that fall. When
Mm.
she described the fall, it wasn't anything significant.
Yeah.
And then baby became unwell, needing more oxygen, nitric oxide, inotropes, no positive culture, CRP slightly raised. Then we did an echo. Last second. Um, yeah, the inotropes. The PDA was 5 millimeter.
Mm.
And recently, even our cardiologist said they haven't come across such a big PDA.
Mm.
No other abnormality found in the echo. So
Mm.
at that stage, we did send fish study
Mm.
because it's just everything was not fitting and the
Yep.
baby
Yep.
became unwell. Yeah.
Yep.
And it turned out the baby was trisomy 18.
Mm. Mm.
Unfortunately, baby passed away after a few days. I mean, he did survive, but he never got better.
No, I think
Yeah,
maybe
yeah,
writing for the
yeah.
baby, and
Mm,
with such a large parenchymal bleed, with
exactly.
coagulopathy right at the start.
Mm,
I mean, for me, that's an intraparenchymal bleed. The question is that secondary to IVH? It's compressive, it's purely parenchymal, so I'd say
yeah.
no, because your
Mm,
ventricles are clear. This is purely parenchymal. And when you have a purely parenchymal bleed, the possibility of an early coagulopathy, low platelets. The other thing is a vascular malformation. So the only other thing that I do is I'd put Dopplers there,
mm,
because you can bleed into the cerebrum with a vascular malformation. And with you getting a diagnosis of trisomy 18, a history of fall,
yeah.
potentially. Yeah, so
Mm,
that's very important. Uh,
mm.
yeah, very interesting scan. Very interesting scan.
Right. Thank you.
Brilliant. And I can, it's very difficult when you have such a distorted midline view. So my compliments. Well done.
Thank you.
God bless
Thank
you.
you.
And thank you
Thank
for
you.
sharing the case.
That's all right. Thank you. Thank you for the whole course, Dr. Alok.
No, no, not at all.
And like Kunal, I'll be in touch for reviewing
Yeah,
other
yeah, yeah.
scans. Yeah.
The
Yeah.
best thing to do is like you accumulate your scans, and then really, if you give me the heads up, Thursday and Sunday are the good days. So we can
Sure.
organize for that. So absolutely no problems.
Okay.
Yeah,
All right. Thank you very much.
my pleasure. Dr. Alberto,
Yes,
you have a
yes.
scan? Yeah,
No, I wasn't expecting.
no problems. It's absolutely fine. Does anybody else have a scan they want to share? No problems. So what I was going to say is, again, guys, just feel free. If you've got any interesting scans that you want to share, give me the heads up. There will be a session this Thursday. Session in the sense, if you want to scan. So there's no mandatory attendance. The course is finished. Everything is finished. But if anybody wants to, then just give me a heads up on Thursday morning that you'd like to present. Even if it's one person, we're happy to sit down 7 to 8, go through scans and see and try and help you as much as possible. So we'll continue doing that for a few weeks until people are relatively happy that they don't want to have peer review anymore. In the interim, whenever you're able, finish your kind of uh, things, just so that you can get an idea of what your certificates are going to look like. So really, again, with the logbook and your masters, what we normally do, and I'm just going to share it with you, is we give quite a detailed reference. Can you see the screen?
Yes, we can see.
Okay. So basically your name, your score, how many scans you've done. Now, really, what I would say is they're peer-reviewed scans and they're not peer-reviewed scans. What I'd like to know is roughly how many scans you've done as part of the course, and I'll take your word for it. I've got a grip of your peer-reviewed scans either through your logbook or through the videos. So we normally keep that in and then really indicate on your course competencies what level you've achieved based on numbers of scans completed. Uh, and then really a detailed reference of which is very personalized to you. So it varies differently for everybody. Uh, like I said, giving you the test, once you've given the test, I can also incorporate your test scores in it with your certificate. Uh, for those of you who want to keep this open-ended and want to get to 50 scans, just indicate to me. Your Dropboxes will be open. You can keep adding scans. We don't have to review all 50, but doing 50 scans kind of gets you to level 4. I'm quite happy to keep your Dropbox open for you to indicate that, look, I've finished 50 scans and we can amend your certificates accordingly. So feel free. You've got the entire year going forwards to kind of try and get those scans. There's no hurry. There's no kind of push. If you have any interesting scans, would be lovely to see them. I'm still learning. I'd love to learn from you. So God bless you all. And yeah, look forward to seeing scans from you. God bless you.
Thank you, Dr. Al.
Can I ask some
Yeah,
questions?
yeah, please.
I was reading through some didactic content.
Hmm.
So one doubt I had that how do you differentiate between periventricular hemorrhagic infarct and periventricular leukomalacia on a scan?
So that's a good question. And I think the kind of time you want to differentiate it is if you're doing a scan later on. Now, a periventricular hemorrhagic infarct will basically be a large grade 4, which is visible with infarction. But that area can evolve into periventricular leukomalacia or a
Oh,
porencephalonic cyst. Both can be seen. So maybe when you're presenting next, Kunal, I'll show you images to be able to differentiate the two. But if you start seeing areas of frank breakdown in the periventricular areas bilaterally, that favors periventricular leukomalacia. If you just
oh,
see a very large cystic area developing in relation to a grade 4, that's a porencephalonic cyst.
oh.
Yeah, yeah.
And what do they lot many places they were mentioning that sometimes you see ventricular striate vasculopathy.
Yeah.
What is that?
Uh, let's cover it when we next do peer review.
Okay. Okay.
I'll keep both those images so that I can show you. It's easier for me to show you on the images to describe it.
Mhm.
Yeah.
Oh. And
Okay.
one more, that
Yeah, please.
supratentorial hemorrhage. How does that, where
Uh,
in the scan, where do we have to look for this if
so
we
basically,
see?
what you're talking about more is cortical hemorrhages, which are seen in relation to the perforating arteries. And they are usually seen with neonatal stroke, neonatal arterial ischemia, when you have uh, congenital heart
HIE or
disease.
some
So more with
congenital?
congenital heart disease than with HIE. HIE tends to be in the watershed regions, involve
Mm,
the kind of watershed regions of the parietal, occipital, and frontal lobes. But cortical infarction, as opposed to the terminology supratentorial infarction, which was previously used,
mm.
basically presents with infarction that is more superficial. So
Okay.
if you go back to the talk on neonatal stroke, it's
Oh,
it's covered very nicely in that. It tends to be described more with babies who have congenital heart disease who develop stroke.
oh,
Yeah,
sure. Thank you.
no
Thank you.
problems. Okay. God bless you all. Have a good evening.